In this next video in our series on EKGs, I'll teach you the basics of how to read an EKG, starting with recognizing the various waves that can appear on an EKG and understanding the intervals. Let's start with recognizing the waves. The waves are named logically in alphabetical order, starting with, not so logically, the P wave. P wave represents atrial depolarization. Notice that the normal P wave is upright. However, as you read EKGs for yourself, you'll find that it is normal for the P wave to be inverted in lead AVR, and in lead V1 it's common for the P wave to be inverted or biphasic. Why these exceptions in leads AVR and V1? Think back to our video on lead placement. AVR and V1 are placed right of midline, while the overall electrical depolarization of the heart moves toward the left. No other leads capture a vector that moves to the right. Thus, AVR and V1 have opposite directionality to their vectors. The second wave that you might see on an EKG is the Q wave. Notice that the Q wave is inverted. You don't always see Q waves, and when you do, it might mean the person has had an MI. We'll come back to this in the methods to reading an EKG video. The next wave is an upright wave called the R wave. And the R wave is followed by an inverted wave called the S wave. Together, the Q wave, R wave, and S wave are referred to as the QRS complex. And as a whole, it corresponds to the depolarization of the ventricles. Note that atrial repolarization also occurs during this time, but it is obscured by the QRS complex. The next wave is the T wave. The T wave corresponds to the repolarization of the ventricles. Notice that the T wave is upright. When the T wave is inverted, it's concerning for coronary ischemia. But there are two leads in which an inverted T wave is normal. Can you guess which two leads? If you guessed V1 and AVR, you are correct. For the reasons explained earlier, V1 and AVR are strange leads and have opposite directionality. The last wave is called the U wave. It is generally not present, but can be present in bradycardia, hypokalemia, hypothermia, and a few other situations. We won't concern ourselves with U waves in these videos because they are uncommon. So that's it. Those 6 waves are repeated over and over to make up an EKG. If you can recognize those waves, you can turn what at first appears to be a page full of squiggly lines into something with meaning. Another important EKG concept is to understand the intervals. But before we start, I just wanted to introduce you to the EKG grid. It's composed of small boxes, and each box represents 40 milliseconds. 5 boxes are usually grouped together into a larger box, which represents 200 milliseconds. Now that you understand the EKG grid, we'll go back to the PR interval. The PR interval is measured from the beginning of the P wave to the beginning of the QRS complex. It basically represents the time it takes an electrical stimulus to get from the atrium to the ventricles through the AV node. The PR interval is normally 120 to 200 milliseconds long. Or since each box corresponds to 40 milliseconds, 3 to 5 boxes long. A long PR interval is called a first-degree AV block. Short PR interval may be seen in an obscure disease, which you may have heard of in cardiology class, called Wolff-Parkinson-White syndrome. The QRS complex, as measured from the start to end, should be less than 120 milliseconds, or 3 boxes. If it's longer than 3 boxes, the differential includes hyperkalemia, bundle branch blocks, and disease of the His-Purkinje fibers. The final interval is the QT interval, which is measured from the beginning of the Q wave till the end of the T wave. This can actually be confusing, because remember the PR interval is measured from the beginning of the P to the beginning of the QRS. So there's not a uniform way in which intervals are defined. The normal QT varies depending on the patient's heart rate. And there's a formula to calculate the corrected QT interval, or QTC. But I don't think you'll be expected to know that formula. An abnormal QTC in males is above 450 milliseconds, and in females above 470 milliseconds. Without having to memorize the numbers or any formulas, a reasonable way to determine if the QT interval is prolonged is to check to see if the QT interval is more than half as long as the R to R interval. Let me show you what I mean. Here's the distance from R to R. Compare that to the QT interval. Notice that the QT interval looks, just by eyeballing it, slightly less than half the length of the full R to R interval, which means in this case the QT interval is not prolonged. Patients with a long QTC are at risk for torsade des points. When you put all the waves and intervals together in all the different leads, you get an EKG that looks like this. Notice that there are a few seconds for each lead, and at the bottom there is a full 10 seconds from one of the leads. This is called the rhythm strip. Now that you understand how an EKG is performed, the waves and intervals that make up an EKG, you are ready to learn how to interpret EKGs. So watch the next video called Method to Read EKGs. So here are the take-home points from our video. There are 6 possible types of waves that make up an EKG: P, Q, R, S, T, and U. Remember that the Q and the U are not normally present. The second take-home point is to know the normal interval lengths.